Welcome to the sixth session in the Data for Health, Data for COVID-19 series hosted by Bloomberg Philanthropies. My name is Carlos Roig, and I'll be moderating these sessions. Last week, we were so pleased to have more than 265 participants registered from more than 50 countries. This week, there are more than 320 participants registered from 63 countries. The session is being brought to you by Bloomberg Philanthropies, an organization founded by Mike Bloomberg that uses data to ensure better, longer lives for the greatest number of people. As you know, the goal of the Data for Health initiative is to partner with countries to improve their public health data. The COVID-19 pandemic has reached nearly every country in the world, and during this crisis, high-quality data is more important than ever. This series aims to provide technical assistance to support your ongoing COVID-19 work. Before I hand this over to our presenters, I wanted to go over a few pieces of information to help you navigate the platform. This webinar will be conducted in English with simultaneous translation to French and Spanish. You can switch languages via the translation button. Time is allotted for moderated discussion at the end of the presentations. Finally, you will notice a chat button at the bottom of your screen if you're using a computer, and at the top of the screen if you're using a phone. Please direct your chat to everyone, which is the default setting. Please use this feature at any time to type questions you have about the presentation or anything related to this series. International Data for Health partners will answer as many of these questions as possible at the end. This session will cover COVID-19 data analysis for public health action. Our first presenter will be Cynthia Driver, Director of the Data Impact Project at Vital Strategies. Cynthia, over to you.
Thank you, Carlos. Next. Even in the absence of outbreaks and epidemics, the public health sector is faced with many decisions and questions that need to be answered. And the COVID-19 pandemic has dramatically increased both the number as well as the speed at which these decisions must be made. The decisions cover health services capacity to minimize the loss of life, public health response activities such as contact tracing, and implementing and lifting measures to slow down spread of the virus, such as sheltering in place and closing schools. For each of these areas, data analysis provides critical evidence to guide the response. Next. Data analysis is not without its challenges, however. We are in a new and rapidly changing context. The data may be incomplete and of varying quality. Our scientific knowledge of the virus is still limited, and we're overloaded with information that's sometimes conflicting. Next. Nevertheless, there are multiple data sources that can be useful and are necessary to provide answers. I'll briefly highlight these here. Vital events reporting systems are fundamental to monitor the pandemic. Deaths, while they're important to track, are by definition a lagging measure of transmission. Notifiable disease reporting systems are a key data source for tracking the number of COVID-19 cases. But when a large proportion of cases are mild or asymptomatic, or where there's low or absent testing, reported cases alone may not capture the extent of illness. Health services data on hospitalization and clinic visits for a range of respiratory illnesses such as pneumonia can serve as an early warning signal for COVID-19. And finally, data that provide information on the social, economic impact, public health perceptions, and adherence to recommendations are key to effective implementation of mitigation measures. Past webinars have focused on the first of these sources, the analysis of excess mortality. So in today's presentation, the speakers will talk about the analysis of these other sources of notifiable disease data for key indicators, health services data on the respiratory syndrome, and lastly, about the use of socioeconomic data. We'll then wrap up by presenting a framework that links these analyses to action. I will now hand over to Maggie Peszkowski from the Data Impact Team and Director of the Cancer Registry Program at Vital Strategies, who will be talking about interpretation of key epidemiology indicators. Maggie?
Thanks, Cynthia. Next slide, please. The daily number of COVID-19 cases and deaths are fundamental to understanding COVID-19 transmission and form the foundation for tracking the epidemic. However, there are several other essential indicators that are important for understanding the epidemic trajectory that can actually be derived from these two fundamental measures and can serve as useful benchmarks for action. We recommend the routine calculation and interpretation of these indicators to provide decision makers with an understanding of the epidemic in their area, to track the effects of public health and social measures, and to guide loosening and tightening of these measures, really in all to assist with public health decision making for action. Next. So the essential indicators that I'll be briefly discussing today include several that you have probably already seen or used yourselves, including new cases or deaths, total cases or deaths, the case fatality rate, the doubling time, and the number of hospitalizations. Next. So here in our first graph, you see the number of new cases in orange and the number of new deaths in purple reported in Brazil as of May 20th. On the y-axis, you see the raw number, and on the x-axis, the date of the report. The number of new cases or deaths reported in a jurisdiction per day is used to form the basic epidemic curve, which you have likely seen several jurisdictions report on a daily basis. Here, it is critical that the case definition be classified according to criteria for diagnosis. For example, confirmed, probable, and suspected. The definition for each of these classes should be explicit, and any changes in definition or reporting should be noted. Now, similarly, deaths attributable to COVID-19 should use the appropriate ICD-10 criteria. New cases and deaths can be used to judge whether our PHSMs are working as anticipated. Next. Here we see a graph of the total cases in Brazil as of May 20th, represented as a line with the number on the y-axis and the date on the x-axis. The running total of cases or deaths to date is also known as the cumulative number of cases or deaths. This measure is reported in conjunction with the number of new cases or deaths each day, and graphing the total number of cases can highlight the general trend. For example, is the curve flattening? Something to note here about scale. This graph is on the linear scale. A linear graph is scaled so that each vertical distance represents the same absolute change in value. Next. Now, you might find yourself in a situation where you have tens of thousands of cases, or where you would like to view the rate of change more easily. In this situation, it is better to use a logarithmic scale. Here, we are seeing the same data as before, the total number of cases, but on a log scale. Using this scale, it is easier to see if this rate is constant or if it is increasing or decreasing. Now, if we use the log base 10, that means that each value on the y-axis is equal to 10 raised to that power and represents multiples of 10 thereafter. So, for example, in this graph, a value of 1 will represent 10 cases, while the value of 2 represents 100 cases because it is 10 to the power of 2. Next. Our next slide highlights the case fatality rate over time in Brazil, represented by a line graph with the percent on the y-axis and the date of report on the x-axis as usual. Now, the CFR is the proportion of people who die from COVID-19 among all individuals who are diagnosed with COVID-19 over a certain period. It's important to note here that within the context of a functioning surveillance system with capacity for COVID-19 testing, the CFR is a measure of disease severity. However, speaking to the challenges mentioned at the beginning of this session, we all know that there are problems with reporting and testing across the board, and so a high CFR could indicate that testing capacity is insufficient, and a low proportion of cases are being identified rather than being indicative of severity. So here we have to pay extra attention to context. Next. We can calculate the doubling time of cases and deaths, shown here again in Brazil over time, in orange and purple respectively. The doubling time in days is shown on the y-axis and the date of the report on the x-axis. Doubling time represents the number of days it takes for the number of cases or deaths to double in value. The lower the doubling time, the more rapidly new cases or deaths are occurring, and so the worse a situation you're in terms of the epidemic. A doubling time of less than 5 days is a trigger for tightening PHSMs. Next. It is likely that the data you encounter will be quite noisy, as reports will not always be consistent. Here we see the 3-day moving average of new cases in Brazil. The new cases are shown in orange bars, while the dark orange line shows the smoother 3-day moving average of new cases. There is only one y-axis, which represents the number of new cases, as the scale is the same. The x-axis, as always, represents the date of the report. Now, the 3-day moving average is a rolling average of any given indicator, and it's used to smooth short-term fluctuations and highlight the long-term trend. One method to calculate it is by averaging 3 figures: the current day's value, the value 1 day prior, and the value 2 days prior. If your data are very noisy, you can consider a 7-day average. Next. Now, in the absence of strong surveillance and testing for COVID-19, tracking the daily number of hospitalizations, as shown here for New York City, with the number on the y-axis and the date on the x-axis, can be a proxy measure that can be used to provide information on how the epidemic is spreading. This will also provide information on what resources could be needed. Now, if possible, rates of new hospitalizations over time should be tracked to judge whether social measures are having an effect. Next. So the essential indicators that we've reviewed here can thus be used to inform public health decision-making. Now, in this work, visualizations such as the graphs and charts that I've shown here, especially over time, are going to be much more meaningful than static values. As we have noted in this section, case report data can be misleading in the context of changing testing patterns. And it is true that data on mortality can validate case report data, but it also tends to be lagged. Therefore, the use of hospitalization data can serve as an earlier indicator of epidemic given these delays. Guidance with best practices on how to use information from indicators is now available, for example, in the form of the COVID-19 playbook, which provides quick, practical access for implementing COVID-19 public health response activities. Next. So in addition to these key indicators, routinely collected data on respiratory diseases are a powerful tool that can serve as early warning for COVID-19 surveillance. To discuss this is Roxana Gina, Deputy Director of the Data Impact Program at Vital Strategies. Over to you, Roxy.
Thanks. Thanks, Maggie. Next slide. Let us start firstly by recalling the sources of respiratory disease data. A common source, of course, is routine health service data, which is captured in health information systems. An example is DHIS2, a system used in 67 low and middle income countries. Routine data can provide information on the true impact of COVID-19 on morbidity, especially as confirmation of diagnosis remains challenging. Respiratory disease data can also be obtained through surveillance systems. This includes laboratory-based surveillance on influenza typing to syndromic surveillance systems. Common respiratory syndromes that are tracked are influenza-like illness and severe acute respiratory infections. These can serve a powerful function during outbreaks. Next. Syndromic surveillance collects, analyzes, and interprets health-related data on a combination of symptoms and clinical signs. An example is influenza-like illness, which is often referred to as ILI. Based on a definition by the World Health Organization, this is an acute respiratory infection with a fever of 38 degrees Celsius or more and a cough. The onset of symptoms should have occurred in the last 10 days. Syndromic surveillance can serve as an early warning system as it detects unusual levels of illness before diagnosis is confirmed clinically or with laboratory testing. Next. Let us look at this image from an article that was published almost 16 years ago and provided the rationale of syndromic surveillance for the early detection of disease. On the x-axis, we see time in days, and on the y-axis, we see the number of cases. In the graph, if we look on the left, we first see the release of a biological agent at time 0 on the x-axis. As we move to the right, we see an epidemic curve for people with the earliest symptoms in black. In this example, this starts on day 2. And then as we continue to the right, we see a blue epidemic curve for people with severe illness, and this starts on day 6. Let us now look at this time between symptom onset for an increasing number of cases and the confirmation of a definite diagnosis. In this graph, it is represented by the alphabet T and is equal to 3 days. So syndromic surveillance aims to identify a threshold number of early symptomatic cases, allowing for the detection of an outbreak a certain number of days earlier than conventional reporting of confirmed cases. In this example, we see that it would be 3 days earlier. Next. During the COVID-19 pandemic, clusters of illness detected in the surveillance system can therefore be used as an early signal in areas where cases have not yet been detected. It can also signal changes in the patterns of disease when there is inadequate COVID-19 testing. And finally, these data can be used to provide an early indication of re-emerging COVID-19 infections after changes have been implemented in public health and social measures. For example, if we start opening non-essential businesses. Next slide. Let us now look at an example. As we see in this news headline on the left-hand side, the first case of COVID-19 in New York City was reported on the 1st of March of 2020. This is equivalent to week 9 of 2020. By week 10, this had increased to 24 cases, and by week 11, there was 1,916 cases in New York. We see this as an increase as a green line graph on the right-hand side. Now, during the same time period, we could also look at emergency department visits for ILI, influenza-like illness, and we see this significant increase already from week 9 to week 10. This would have served as an early warning of the approaching burden by 1 week. Now, one may want to say that increase doesn't look as dramatic, but the value of syndromic surveillance is in comparing the current year's data to historic information. Next slide. Here we are looking at just the emergency room visits for influenza-like illness by week. The data for 2020 appears as a blue graph, and the number of cases for the previous years are presented as gray graphs. When compared to the previous years, we can see how unusual this increase in ILI emergency room visits were in weeks 9 to 11 of 2020. Next slide. To assist with similar analysis in other countries, a technical package has been developed outlining the steps to follow and providing practical guidelines. Templates are provided for data analysis, visualization, and the presentation of results. Next. In terms of the steps, ideally, data should be available and analyzed at least on a weekly basis. One could look at a few indicators to identify the trend in new cases or deaths due to a specific respiratory syndrome. So for example, one could look at the number of cases due to severe acute respiratory infections or ILI per week. Historic data, preferably for the last 3 to 5 years, helps to establish a baseline and also provides an alert threshold. Next slide. The package includes templates for establishing a baseline using an approach provided in the World Health Organization's Global Epidemiologic Surveillance Standards for Influenza. A screenshot of the instruction page is presented on the left side. And on the right side, we see the percentage of ILI visits out of all outpatient visits in the United States for the years 2015 to 2019. As you can see, the graph looks quite busy. So this data are reassembled in Excel to provide a single baseline that can be used then when looking at the 2020 data. This is presented on the bottom right-hand side of the slide. Next. An alert threshold is then defined, which is usually the upper limit of either the 90 or 95% confidence interval, depending on how conservative a country wishes to be in the identification of potential outbreaks. There is merit in keeping a low threshold, as this then can serve as an early warning signal, which could then trigger further investigations. On the right-hand side, we see the data for week 30 of 2019 to week 15 of 2020 from the US, and this is presented as a red line graph. This is then compared to the baseline and alert threshold for the US that we saw on the previous slide. In week 2020, this threshold was exceeded in week 11. Next. Analysis of syndromic surveillance data can therefore be used as one of the indicators to inform the implementation and timing of mitigation measures. For example, a steady increase in influenza-like illness for at least 10 days above the seasonal average or baseline can indicate that mitigation measures are needed. Here we see an example from the US of emergency department visits for COVID-like illness and influenza-like illness. The trends over time match with influenza-like illness exceeding COVID-like illness for most weeks, thus more likely to trigger a warning. This indicates that influenza-like illness can provide a good proxy measure for underlying COVID-19 infections in the population and serve as an early signal of disease. Next slide. Now, there are some matters that we would need to consider when using surveillance data. Firstly, ongoing surveillance systems can vary by country, and in many instances, there could be more than one surveillance strategy being implemented in the country. As a result, a range of health management information systems or data collection processes may be used to record the information, thus making the retrieval and the analysis of data more challenging. However, once you have completed the analysis and you have the results, these should be communicated to decision makers so that appropriate action can be taken. And then finally, early warning surveillance should not detract from the routine analysis of data on other health conditions and essential health services during the pandemic. I'm now going to hand over to Emily Myers, Senior Technical Advisor in the Data Impact Program. Emily will now discuss the socioeconomic data sources that we can use for COVID-19 surveillance. Over to you, Emily. Thanks.
Thanks, Roxy. Next slide, please. So in the absence of a vaccine or treatment, public health and social measures remain our best defense against COVID-19. But the most powerful measures that we have available, those that restrict movement, such as stay-at-home orders and school closures, have significant social and economic costs. So for example, there are clear impacts on livelihoods. We're worried about indications of increases in domestic violence across many contexts. There are concerns about emerging food crises around the world and rising educational disparities. So we need to weigh these and other social and economic issues when making decisions about the COVID-19 response. Next slide, please. Social and economic well-being are affected by public health and social measures, but they also affect the implementation of these measures through their impact on adherence. For example, in many contexts, we're seeing lack of adherence to measures among informal sector workers who don't have access to social insurance programs and therefore may have no recourse for lost wages. We also see how exogenous events, so for example, the cyclone in India and Bangladesh last week, can complicate the implementation of COVID measures and increase the risk for disease transmission. Likewise, the way that public health and social measures are implemented and any relief measures that accompany them can either exacerbate or mitigate their social and economic impacts. Next slide, please. It's therefore critical to monitor social and economic indicators to help inform and guide the public health response. And monitoring these indicators can have several key benefits. First, this allows governments and communities to work together to adapt measures in a way that minimizes burdens and mitigates the harms of the measures. Just for example, more than 100 countries have introduced or scaled up cash transfer programs to citizens in order to offset some of the income losses that households are facing due to the COVID-19 crisis. Secondly, in decisions around when and how to loosen public health and social measures, data are really key to weighing the various trade-offs that are involved. And finally, having data on public perceptions enables governments to design clear and effective risk communications that can increase public support for the response. Next slide, please. This slide shows an indicative list of indicators and data sources for tracking social and economic impacts of COVID-19, as well as public adherence to public health and social measures. In terms of social impacts, some areas that you might want to monitor include knowledge or how well informed communities are about the epidemic, risk perceptions around the disease, and public security, including any rise in violence or insecurity that individuals or communities are facing. In terms of economic impacts, you may want to measure the effects on unemployment, food security, prices of essential goods, and overall levels of economic activity. And to assess adherence, you may want to understand public support for various government response options and track patterns of population movement. You might also want to look at adherence to other preventive recommendations as well. So some of the data sources that we can use to monitor these impacts include rapid polling or surveys, social and traditional media analysis. So for example, to track trends in misinformation about the virus or public sentiment towards government measures. Incident reports can also be useful. So for example, reports of demonstrations or security incidents that are affecting communities. There are crowdsourced data, which might be available, and these could come either from the public or from panels of experts. Administrative data sources. So for example, applications for social insurance or unemployment benefits in order to monitor unemployment effects. And mobility data in order to understand adherence to public health and social measures. And this isn't meant to be an exhaustive list. The available data sources and the indicators of interest will vary significantly by country. Next slide, please. Understanding public perceptions around COVID-19 enables us to better engage with communities in designing and adapting measures and can also guide risk communications. Many governments are rolling out public opinion surveys or polls, and there are also private sector and international efforts to assess public opinion in more of a cross-country way as well. Some of the key constructs or areas that you may want to consider monitoring through polling are knowledge about COVID-19, the prevalence of misinformation, the public sources of information, where they're getting their information about the epidemic, their risk perceptions around how likely they are to contract the disease, personal behaviors and predictors of adherence to public health and social measures, and finally, trust in and support for government. Given the dynamic nature of the pandemic, repeated survey waves will generally be needed, and these can include a mix of core variables that can be monitored over time, as well as dynamic or changing variables that can reflect the evolving situation. So for example, early in the response, you may want to measure support for the introduction of new public health and social measures, but later on you'll want to focus more on the economic challenges that households are experiencing with these measures and their expectations around the continuation of measures. Of course, the need for rapid data complicates some of the typical survey best practices and affects the methods that we can use for data collection. So for example, household surveys are not currently possible in most places for obvious reasons. And most governments are using telephone or online surveys and using techniques like random digit dialing in order to build representative samples. There's also limited time in this context for developing and testing new survey questions. And this can be mitigated in part by using or adapting questions from existing survey instruments where possible. Next slide, please. As an example, we're working on a project with the Africa Centers for Disease Control and Prevention, World Health Organization, and several other partners called the Partnership for Evidence-Based Response to COVID-19 in Africa. And under this umbrella project, we've worked with the public opinion research firm Ipsos to carry out a survey of 28 urban areas across 20 African countries. The poll was conducted relatively early in the outbreak in Africa at the end of March and early April. And so the survey data provide a snapshot of public perceptions among the urban communities in Africa most likely to be affected by the pandemic at that early stage. The chart on the left illustrates our findings on perceptions. The blue bars represent the percentage of respondents who thought that COVID-19 would be a problem for their country as a whole, while the yellow bars on the right represent the share of respondents who felt that they were personally at risk of contracting COVID-19. And you can see that across all regions, many more people thought that COVID-19 would be a national problem compared to those that saw themselves to be personally at risk. And there are many potential reasons why we might see this pattern, many of them perfectly valid. But one concern is that if people don't consider themselves to be at risk for contracting the illness, they may be less willing to adhere to preventive measures. We also measured prevalence of misinformation, and those results are shown in the chart on the right. We found that there was significant misinformation early in the pandemic, including some myths that could lead to stigma or contribute to a false sense of protection. For example, 57% of people thought that COVID-19 could be prevented by drinking lemon and vitamin C, while 20% thought that Africans couldn't get COVID-19 at all. And these types of data can inform risk communications to counter these myths and misinformation. In further survey rounds, we'll plan to capture more data about evolving perceptions, as well as some of the socioeconomic impacts that households are experiencing. Next slide, please. To make the best use of social and economic data, it's important to synthesize data from different sectors. As an example, this chart brings together data on COVID-19 cases, public health and social measures, and population mobility for South Africa. The top half of the chart shows COVID-19 cases on a log scale, which are represented by the yellow line. And the blue dots mark the dates on which the government introduced various public health and social measures. The size of the dots corresponds to the number of measures introduced on that date. March 26th, which is represented by the first larger dot that you can see just before the inflection in case growth, is the day that South Africa's lockdown took effect. So that's when all South Africans were asked to stay at home and non-essential businesses were closed. The chart on the bottom half of the slide shows population mobility, and this comes from Google Community Mobility Reports, which provides data on population movement based on Android phone users. The data are disaggregated by types of locations. So here we're showing retail and recreation sites. And these data are publicly available for most countries in the world. For South Africa, we can see a stark decrease in trips to retail and recreation sites starting on the same day, March 26th, that the lockdown became effective. And taken together, we can see that the lockdown corresponded with a sharp drop in population mobility, as well as a reduction in the rate of growth of new COVID cases in South Africa. And these data provide suggestive evidence the lockdown was both effective in reducing population movement and also had an impact on disease transmission. Of course, we can't infer a causal relationship from this type of visualization, but further analysis of the trends across different countries and data sources can begin to inform the ongoing and future responses to the pandemic. Next slide, please. Finally, I'll wrap up with a few considerations to keep in mind in determining how to best use social and economic data to guide the COVID response. First, many of the traditional economic indicators that we often use, such as economic output or GDP, employment, and household consumption, are either lagged indicators or they're infrequently measured, meaning that they're really of limited use in monitoring a rapidly evolving situation. And this is particularly true in low and middle income countries. So this means that we're going to need to be creative in identifying non-traditional data sources and proxy indicators that can help us to rapidly and continuously assess economic impacts at the household level. In order to do this, one key recommendation is to aggregate information that's held at different levels of government and also to engage with stakeholders outside of government, including community groups, NGOs, and the private sector, in order to gather as much relevant data and information as possible and draw on local sources of expertise and awareness. And finally, while governments have an interest in tracking personal data to monitor population adherence to measures and also risks for transmission and other indicators, we need strong frameworks for data privacy in order to protect personal information from misuse. And now I'll hand it back over to Cindy, who's going to wrap up the presentation by relating these data to a framework for decision making. Over to you, Cindy.
Thank you, Emily. So in this webinar, we've discussed various sources of data that can be used to guide public health action. The real power of these data come when they're tied to a clear decision-making framework. Next. One such framework is an adaptive response to the epidemic, which provides for dynamically adapting the response as the epidemic progresses along the epidemic curve. The indicators and data we've talked about today are used to inform where we are along the curve and how other sectors are faring. So this graphic visualizes the phases of the epidemic curve along the top of the slide and the essential activities along the left-hand column. And in the center, that you can see the timing of the activities. You can see that different activities are phased in and phased out over the course of the epidemic. For example, testing and contact tracing are critical interventions, but may not be feasible to implement at scale at the peak of the epidemic. In contrast, social, economic, and emotional support should be provided from the early stages of the epidemic and throughout. Next slide. A tool that can be used to operationalize an adaptive response approach is an alert level system for guiding, communicating risk levels and the corresponding public health and social measures. In this table, key indicators are shown in each row, grouped according to the domain. For example, the epidemiology of cases, the healthcare system capacity, disease control status, and economic and social impacts. The columns then show the benchmarks or triggers that determine the COVID risk level. Some of the benefits of this approach are transparency, accountability, the clarity of communication is easy to understand, and that it can be applied at both a national or at a subnational level. There are also challenges. we recommend that establishing a core working group as well as an independent review to define the indicators and alerts thresholds. Reaching consensus on indicators and appropriate benchmarks can be a challenge. Another challenge is the high frequency of data needed for core indicators, which requires adaptation and creativity to identify proxy measures. And finally, without effective communications and efforts to build public trust, these systems most surely are ineffective. Next slide. In this slide, we can see some examples from a few of the governments that have rolled out alert level systems, from the governments of South Africa, the state of Utah, and New Zealand. This brings us to the end of the presentation portion of the webinar. We now look forward to hearing some of your questions. And Farnaz Malik, Technical Advisor in the Data Impact Program of Vital Strategies, will be moderating the Q&A session. Farnaz, over to you.
Thank you, Cindy. For the Q&A session, we have some questions that came in during registration, as well as during the presentation. We are joined by our panelists, Michael Washington from the Centers for Disease Control and Prevention, Lynn Sferaza from the Global Health Advocacy Incubator, Tim Adair from the University of Melbourne, Oliver Morgan from the WHO, and myself, Farnaz Malik from Vital Strategies. We have about 15 minutes to answer some of these questions. The first question comes from the Philippines, and I will ask Tim if he can answer it. What should countries do with incomplete death data, especially on causes of death due to the halt of registration and processing?
Okay, thank you. That's a good question. Firstly, what you can do is actually assess the extent of decrease in registration due to the pandemic. So you can perhaps look at the percentage of registration points that are reporting, so you can get an understanding of what the impact is. In the webinar 2 weeks ago, we presented some methods of measuring excess mortality where you have incomplete death registration data. And you can also make adjustments for decreases in registration, for example, if there's maybe 20% of registration points not reporting. Also next week, there will be a webinar in this series looking at using the Anaconda software tool to assess the quality of mortality and cause of death data during the pandemic. And that's especially useful where you have suboptimal quality data. So I think, yeah, it's really applying some of these methods we've presented on, assuming that the halt of registration is not so bad. If it is a case where the majority of registration points are not reporting, it may be just simply a case of waiting until the data come through, because it's preferable to use data that produces reliable estimates of mortality, even if you have to wait a while for the data to come through.
Thanks, Tim. Our second question, I'll ask Michael Washington to answer. We've seen a lot of institutions publish results from modeling. How can we interpret these results and use this information for decision-making?
Thank you, Farnaz, for the question. First, one has to examine the models that are being used and make sure that it fits your situation. Some models use data from other countries, or their assumptions may not fit your situation. Please take time to see what these models are doing and what inputs they are using. After all that, work with the models that match your situation. If they all say the same thing, then that is good, and you can make your decision based upon that. If they are all saying different things, you can either put more weight on the model you think matches your situation the most and use the rest to supplement your decision. Usually over a short run, most of the models will say the same thing. For long-term decision-making, focus on mechanistic models that match your situation. And we'll talk in more detail what mechanistic models are and other types of models during a webinar on the 10th of June. As for what to do with the results, that is the decision maker's job based upon the information they have. The one thing models nor we can do is tell what to do based upon what the model says. Thank you, Fernand.
Thanks, Wash. This next question comes from the Philippines. I'll answer and then I'll ask Maggie to add anything given her session's topic. How does a country know when its curve is flattened? Flattening the curve is implementing measures to slow a virus's spread to reduce the peak in the number of cases and thus reduce the demands on the healthcare system. As we learned in this webinar, and there are some key epidemiology indicators to monitor to understand the COVID-19 epidemic, namely the daily number of cases. When the number of cases per day starts to decrease, the curve is flattening, but it will be important to continue monitoring the number of cases and deaths to determine if and when to loosen and tighten public health and social measures. Maggie, I'll now ask if you have anything to add.
Thanks, Farnaz. I only have one thing. There are some mathematical quantities that you can look for on specific curves to help you judge whether you are flattening a curve, and we can send those resources out after the webinar. Thank you.
Great, thank you, Maggie. This next question is for Oliver. How can we assess the impact and effectiveness of public health and social measures?
Thanks, Farnaz, for the question. I think there are three parts to this question, or three parts to my answer to this question. I think that the first is clearly collecting information about the public health and social measures in the first place. And Emily covered most of this in her presentation. It might be useful for attendees to the webinar to know that there is a taxonomy that's been developed by WHO to define public health and social measures, as well as a data set about public health and social measures in most countries around the world. And that's available for everybody online on the WHO website. So I think that's the first step, is to be able to measure your public health and social measures and keep a track of them over time. That's an important one. The second element is to have a good set of data about the epidemiology in the area or the population you're interested in. And we also had presentations from Magdalena and Roxana around that, about how to assess and track the epidemiology of COVID-19. And then the third element is to use a number of different methods to look at the relationship between public health and social measures and the epidemiology of COVID-19. There are quite a number of different approaches one could take. One could take some quasi-experimental approaches. There are quite a number of modeling approaches that can be used. It is helpful to look at multiple populations to see whether there are impacts from public health and social measures that are repeated across populations, and that's also very important to understand. And then there's also a scenario assessment approach by which one can take the data that is available and use that to help build scenarios to try and assess whether the application or release of certain public health and social measures, what type of impact those would have. Thanks, back to you.
Thank you, Oliver. This next question is from the Gambia, and I'll direct it to Lynn. How can we improve vital registration of COVID-19?
Well, thank you, Farnaz, for that question. In order to make sure that we are capturing all COVID-19 deaths in the civil registration system, we need to make sure that the civil registration system in your country continues to function throughout the pandemic. We addressed this in last week's webinar on maintaining civil registration during COVID-19. But just briefly, some of the things we talked about that some countries were doing were countries that used to require in-person registration for births and deaths, are trying to quickly transition to electronic registration to ensure continued registration of events during the pandemic. But also, civil registration offices should remain open during this time for those people who can't register electronically. And where that's the case, civil registrars should be taking protective measures to protect themselves and the public. So there should be social distancing measures in place. Registrars should be wearing a protective equipment and ensuring that there are no crowds in the civil registration office. If you'd like to get more information on how to maintain civil registration during this time, please look at the webinar that's online from last week. And you can also go to the UN website on the legal identity agenda. They have collected survey results on countries maintaining civil registration. And there's a wealth of information on the UN Legal Identity Agenda Task Force website. Thank you.
Great, thank you, Lynn. This next question is for Roxy. This is from the Democratic Republic of Congo. I think that an up-to-date collection system is key for the analyses that you discussed. What is your experience?
Thanks for the question, and thanks for Naz. So yes, syndromic surveillance data and using it as an early warning system will not be possible in every country. One of the key issues is around data quality. This has to do with completeness of data, looking at the reporting over time, and then as well, the lagging in terms of information obtained on in the current setting in 2020. So yes, if you have very delayed data collection in terms of retrieval, it will then not serve as an early warning system. You could put in place certain measures or activities to try and collect the data on a more rapid basis so that it can serve as a way of informing action. And that you can do as a measure during the pandemic. But data quality is an important issue. There are other issues as well that could help in terms of using syndromic data. The one is it also depends on the size of the outbreak. It also depends on the population dispersion in terms of those who are affected. Again, as Maggie also mentioned, definitions are very important. So knowing that people are using the same definitions when they're collecting the information and they're defining a syndrome as influenza-like illness or severe acute respiratory infection. And then finally, also deciding what's your criteria in terms of when are you going to take action. And then finally, the last one is actually having providers who can identify these syndromes and actually report on unusual cases. Thanks, Farnaz.
Thank you, Roxy. This next question I will direct to Michael Washington. How do you choose measures that will have the most impact with minimal resources a country has?
Again, thanks, Farnaz, for that question. So that really has to do with two things. First, you have to look at the intervention and see how effective those interventions are. And your measure of effectiveness will depend upon what you're measuring as far as effectiveness, as far as the number of deaths, the number of cases, the number hospitalized, whatever you want your effectiveness to be. The second part is the resources that are required. So how much resources will be needed in order to implement those interventions? And from that, you should be able to conduct an economic analysis to see if what would your outcome be or your effectiveness of the intervention be based upon how much resources you put into play. Probably the most difficult part will be getting those types of data, especially the resource part, or how much it will cost to implement those interventions. I don't know if there's already a list out there that demonstrates what's considered like a cost effectiveness per intervention. But if there are none, you're going to have to go through those steps to determine those factors and calculate your own cost effectiveness analysis. Thank you, Fanon.
Thanks, Wash. We have time, I believe, for one more question, which I will direct to Maggie. or possibly two more questions, which I'll direct this one to Maggie. It is from Rwanda. How can we measure the unusual patterns for COVID-19 reported cases for countries with limited data or fewer testing?
Thanks, Farnaz. I think that's a difficult situation, and I think many countries are facing that, where you don't have a robust surveillance system with testing capacity to be able to actually detect COVID-19 cases. I think there you are going to have to put on your thinking cap and become a little bit more inquisitive and turn to these other data sources. And that means you are going to be going to your deaths data, to the hospitalizations data, anything you can get from DHIS2, for example, going towards syndromic surveillance. So really seeking these answers from alternative data sources as the testing capacity is improved within that country. I think those are going to be your best bets. And I think you can go towards rapid mortality surveillance. I know we've shared information on that in the past. So that's also another avenue. Thank you.
Great, thank you, Maggie. Okay, now I believe we have time for one more question. I am going to direct this question to Cindy. What's the role of local government in contact tracing, and what can the data tell us?
Local government is key to this kind of activity. It's the most traditional public health intervention. It's served to control many epidemics over time, and it's based on the idea that the number of cases have come down sufficiently so that each new case is identified, interviewed to determine who are all the contacts, and then those contacts can self-isolate to prevent spread to other cases. And so it's a mechanism, that a tool that can be brought to bear as the number of cases are starting to come down from the peak, and really requires incredible amount of resources, but done effectively is one of the best ways to, in a targeted way, continue to suppress the spread of the virus.
Thanks, Cindy, and thank you very much for all of the questions, and thank you to our presenters and panelists for answering them. Any questions that we were unable to address will be answered after the webinar. Over to you, Carlos.
Great, thank you, Farnaz. And thank you to our presenters, and thank you all for joining us. Our next session will be at this same time, Wednesday, June 3rd at 8 a.m. Eastern Standard Time. It is entitled Assessing Quality of Mortality and Cause of Death Data During COVID-19. Please note that today's session has been recorded, and we will circulate this recording and the accompanying slides to the group. When the session ends, you will be prompted to take a short survey, which should only take a few minutes to complete. We will try to respond to most unanswered questions in a subsequent email or session. Thank you again for your participation. We look forward to hosting many of you during the session next week. Please look out for an email with more information on that. Thank you.